Dumbbell is also, yes. He's passive, but yes. Oh my gosh,
Seeing Brian jump.
yeah. Yeah, no, I think so. I think he understands his humor. His humor is not for everyone.
Oh, no. Thank you.
Sure.
Like the skeleton crew. Does this, oh, this, I guess I can put this.
Yeah, yeah, absolutely.
This.
Okay. We are going to go ahead and get started with our very last panel of the day. It is a pleasure for me to introduce the moderator for the last panel. The last panel is entitled Clinical Ethics in Contemporary Society. And I do think that this series of talks is really a critical set for us to consider. Our moderator is Julie Kaur, who is an associate professor of obstetrics and gynecology in the section of complex family planning and an assistant director of the MacLean Center for Clinical Medical Ethics. After completing medical school, residency, and a fellowship in family planning and an MPH at the University of Illinois, Julie is a dedicated educator. She is the program director for the Fellowship in Complex Family Planning, assistant director for the MS3 Obstetrics and Gynecology Clerkship, and co-director for the Pritzker School of Medicine first-year doctor-patient relationship course. So it's really a pleasure for me to introduce Julie, who will be moderating this panel and giving the first talk.
Thank you so much. And I'm totally going to shame my husband who's not back from snacks yet. Brian, can you hear me? This is amazing. That's all right. Oh, there he is. Okay. I just called you out, Brian. So I'd like to thank my husband, Brian. And of course, I'd like to thank Dr. Angelos and Dr. Siegler. Your support and mentorship and really kind of your exemplary leadership have really been inspiring, and I look forward to continuing to work with both of you going forward. So I'm going to get started. Oh. I'm setting my clock. I'd like to set the tone and the expectations for the session. Though some surgeons may not recognize this, as an OBGYN, I am a surgeon. And as a surgeon, I am going to keep us on task with regard to time. I'm not going to be rude, but I am going to try to keep us on target. And I'm probably already like messing that up, but we're going to go. Okay, so I'm talking about, is legislative anxiety an indication for surgery? Contemporary culture and contemporary society is what I deal with. I mean, we all deal with, but in my practice as a complex family planning expert, my day-to-day practice really is shaped by contemporary society and law. So this is a take on that. I have no conflicts. Learning objectives for this talk is that by the end of this session, you should be able to describe recent laws impacting reproductive health. You should be able to discuss patient concerns regarding reproductive autonomy, appraise ethical issues when considering requests for permanent sterilization, and finally, apply a framework for considering sterilization requests. So as always, in clinical medical ethics, we start with the patient. This is a 23-year-old G0, which means she's never been pregnant, presenting for tubal ligation. This patient has never desired biological family building. She has sought tubal ligation twice before, right after turning 21, and was told by both of the doctors that she'd met with that she was too young and that she would have to wait until the age of 30 before being able to have a tubal ligation. She has no significant medical or surgical history. She does have a history of chlamydia, treated in college. She also had an IUD placed several years ago that came out. It was malpositioned. And so that's her contraceptive history. She reports that her interest in pursuing tubal ligation was reignited for some reason on May 2nd, 2022. Can anyone guess or venture a guess as to why that date might have inspired her, why she might have been inspired on that date? Anyone in the audience? For those of you who may not remember, this is the date that Politico leaked the Supreme Court Dobbs decision. That the leak ended up being pretty consistent with the final decision that would ultimately overturn Roe versus Wade and essentially return the decision as to whether abortion would be legal to the states. So this patient expressed concerns about not being able to obtain an abortion if she were to become pregnant at some point in the future. She also expressed concerns that contraception may potentially also be restricted or banned. So this leads to the question, is legislative anxiety an indication for surgery? In the wake of the Dobbs decision, there's been an increase in the number of requests for sterilization. These are I could keep going on and on, but just to give you a few examples in the lay press about this. So post-Roe, more Americans want their tubes tied, and it isn't easy. Permanent birth control is in demand, but hard to get. More women are seeking sterilization since Roe versus Wade was overturned. And this is a patient quote in a newspaper article. I feel much more in control. In a post-Roe America, Philadelphians consider permanent control procedures. So themes that have come out, we've now at the University of Chicago seen quite a number of these patients who are young, many under the age of 30, and that number 30 is going to come up a few times. Many are nulliparous. For those of you who may not have studied obstetrics and gynecology or who may be distant or remote from your clerkship, that means they've never been pregnant. Many are fearful of not being able to prevent or terminate an undesired pregnancy. And many have been turned away when previously requesting sterilization. Some have used long-term, highly effective contraception, such as IUDs or contraceptive implants. So just to review some legal considerations. So the Dobbs versus Jackson Whole Women's Health case. Jackson Women's Health Organization was Mississippi's sole abortion clinic, and they sued to overturn Mississippi's 2018 law banning abortion above the gestational age of 15 weeks. The SCOTUS decision, as I said, was leaked on May 2nd, 2022. We can discuss where I was when that came out. It's kind of one of those Challenger, or Kennedy assassination moments. So I'd be interested to talk to you about that after offline. The decision was officially released June 24th, 2022, and then overturned Roe versus Wade and allowed states to determine the legal status of abortion. Since the Dobbs decision, states have fallen like dominoes. This is a map, and I tried to get a more recent map in the past week, But the Center for Reproductive Rights, last time I checked, hadn't updated their map since the Tuesday election, which has changed this map. We are a donut hole in the Midwest, in Illinois, where our state has no restrictions on abortion, but we are surrounded by states that largely ban abortion. Indiana's laws enjoined as they're going to a federal court. Michigan, another Midwestern state, went entirely blue for those Michiganders here. They totally went blue and legalized or codified abortion into their state constitution. But we're not going to go into all these different laws. And there's a looming federal abortion ban. Lindsey Graham, I'm trying not to get political, but it's impossible, but Lindsey Graham introduced a federal abortion ban on September 13th of this year. And that would ban all abortions above the gestational age of 15 weeks. So those are that's a very brief description of the legal landscape around abortion since Dobbs. How about contraception? Because that's something that a lot of our patients have been concerned about. You know, if they're doing this to abortion, it's only one step away from contraception. The right to contraception was enshrined in the Griswold versus Connecticut decision in 1965, and that was a case protecting married couples' rights to buy and use contraception without government restriction. And that was based on a right to privacy. For those of you who may have some familiarity with Roe versus Wade, that also was based on the right to privacy. Justice Thomas wrote in the Dobbs decision that in future cases, we should reconsider all of this court's substantive due process precedents. Really, he called out essentially contraception as something to be reconsidered and the right to contraception as something to be reconsidered, as they essentially struck down the concept of a right to privacy in the Dobbs decision. Personhood amendments are amendments that have popped up here, like it's kind of whack-a-mole, have popped up periodically, and they basically would say that from the moment of conception, the embryo has a right to full rights. And under that, some claim that certain methods of contraception would be illegal. And there are specific contraceptive bans that also kind of get at this as well. Focus on emergency contraception, erroneously stating that this is an abortifacient, which is absolutely not. And certain IUDs also claiming that those are abortifacients. So the idea that contraception could be banned is actually not far off. So let's think about some ethical considerations here and returning to our four core principles. So thinking about how non-maleficence applies to our counseling of patients who are young, who may not have ever had pregnancies, and who are expressing real concerns and desires to obtain sterilization based on the current legal landscape and concerns about what may happen in the future. So let's think about some medical and psychosocial risks associated with tubal ligation, right? Because as you know, you saw in some of those headlines, the report that our patient gave us that she had seen 2 prior doctors and been turned away because she was deemed too young. This is not rare. People are having a hard time obtaining these procedures when doctors are feeling uncomfortable proceeding. So what are some of the medical or psychosocial risks associated with this surgery? Some medical risks include risk of blood transfusion, risk of infection, which is quite low. These are generally performed laparoscopically with low but not zero risk of infection. Small risk of readmission and risk of failure, depending on the approach. The success of a tubal ligation may range from less than 1% risk of pregnancy to up to 2 to 3%. And it increases with duration from the moment of from the time frame of when the surgery was obtained. Those who do experience pregnancy after tubal ligation are at a much, much higher risk of experiencing ectopic pregnancy. So these pregnancies are certainly not benign. psychosocial, the risk of regret. And this is where that 30 years old kind of comes in. There was a large study, kind of one of our landmark studies in obstetrics and gynecology is called the CREST study, and I'm not going to go into the acronym, but essentially it prospectively followed nearly 10,000 people after sterilization for 10 years, looking at a number of different outcomes. One of the papers that has been really most frequently cited is that which looks at factors that are associated with increased risk of regret. And the age of under 30 is very consistent, is significantly associated with increased risk of regret, meaning down the line, people thinking, oh, I wish I hadn't done that. I would like to try to achieve pregnancy. That paper came out in 1999. More recently, in 2000, 2002, additional researchers looked at cross-sectional data, so large national data sets that reconfirm that the age of 30 or under 30 rather is is associated with an increased risk of regret. So this is real. This is, well documented, well researched, and, we're not going to do a randomized control trial ever looking at this. And so a prospective cohort study is pretty much the best quality of evidence that we're going to have. And, when thinking about the risks, we always have to think about the alternatives. There are very effective, very long-term and safe options to tubal ligation or permanent sterilization, long-acting reversible contraceptive methods, so intrauterine devices, and the next one, the contraceptive implant, which are effective for many years, and the risk of pregnancy is less than 1%, and of course does not require surgery and the associated risks. So beneficence, let's think about how tubal ligation may be beneficial to the patient in front of you. I want to make sure that we don't pathologize pregnancy. Sorry, Luke, I know that kind of the kind of placental considerations and viewing the pregnancy and the placenta as a potential friend or foe. That framework I think is very eloquent. And is really important. But I think it's also really important not to pathologize pregnancy. However, that does not mean that pregnancy is a health neutral state. Unwanted pregnancy in particular is associated with numerous sequelae. And again, there's really eloquent data looking at the risks of continuing an undesired pregnancy, prospective cohort studies of people presenting to an abortion clinic before and after, kind of above and beyond the gestational age limit for that clinic. And I just want to make sure I'm not, okay, I'm going to keep going. And so following people who were and were not able to obtain their desired abortion. And the study called the Turnaway study found that continuing undesired or unwanted pregnancy is associated with health, psychosocial, and financial sequelae, which is not really surprising. Additionally, the risk of pregnancy may be especially challenging or risky for those with underlying medical and psychosocial concerns. Furthermore, there are actually health benefits to a salpingectomy, which is at this point the way that many of us are performing tubal ligations, which is completely resecting the fallopian tube. And that's because the theory is that many ovarian cancers actually start at the level of the fallopian tube and the fimbria specifically. And so if we remove the fallopian tube and the fimbria, we actually decrease the risk of ovarian cancer. And there, again, is strong research supporting that. So autonomy, honestly, to me, it's like a no-brainer. So, clearly the people who are coming to us feel that there is an imperative to protect their bodily and reproductive autonomy. Abortion bans and potential contraceptive restrictions or bans threaten their capacity to actualize their autonomy. And then finally, justice, which is incredibly important to consider when we're talking about reproductive health. As there is a dark history of coercive sterilization. And I wrote history, but actually it continues to the present. So we have to be really cognizant of this when we're talking about sterilization. We also have to recognize that there are implicit biases as to who is and who is not deemed appropriate for sterilization. And when we look at rates of sterilization, those rates are much higher amongst Black, Brown, uninsured, underinsured, and individuals who are low income. Now, it may be that those individuals are more interested in obtaining tubal ligation, but actually when you look at counseling practices around counseling for permanent sterilization change when we look at these different factors. Then also we have to be thinking about whose fertility is preferentially valued. Lisa Harris at the University of Michigan has written eloquently about how we value fertility. And when we think about, for example, insurance companies and their coverage for in vitro fertilization, people who are more affluent, who have access to resources are much more able to access in vitro fertilization and get pregnant. Whereas those who are actually more directly benefit from in vitro fertilization, those with tubal factor infertility, are less able to access pregnancy services or in vitro fertilization. And those people are more likely to be, again, people of color, low-income individuals. So again, we have to think about how we're thinking about and valuing fertility. So, as I said, a lot of these patients are being turned away, trying to seek their tubal ligation. So we have to think about, why are these patients being turned away? Additionally, we need to be considering, does the Dobbs decision and the specter of future contraceptive restrictions or bans change how we consider requests for tubal ligation from young nulliparous patients, and should it? So I think we need to really be kind of focusing on the loci of discomfort when patients are presenting who fit this kind of picture and are requesting sterilization. Those loci are threefold. One is the young age. Secondly is nulliparity, so not having children. And additionally, these explicit statements of anxiety over legislation that is real or threatened. So in thinking about how to counsel these patients, we have to ask some questions of ourselves. First and foremost, we're ethicists, and so we're trained to do this. Does this patient have capacity? A number of patients have actually, and colleagues have asked, should we be getting psych consults to make sure that this patient is okay to make this decision? There's actually a legacy around this. ACOG used to recommend that people seeking tubal ligation discuss this with 2 prior physicians and a psychiatrist prior to obtaining tubal ligation until 1970. And I think that we are trained to use Applebaum's criteria, and we have to really empower our colleagues that they are able to assess capacity for decision-making. They may not be kind of thinking about that, but we do that every day, and we need to be able to empower our colleagues to do so. Additionally, does this patient demonstrate consistency in their decision? These patients have really overwhelmingly described longstanding interest in obtaining tubal ligation. Some of them report knowing that they never wanted to have children, even as young as childhood. One more. So how should we consider these data on regret and those who are under the age of 30? Should this be an absolute cutoff? I can tell you that many OBGYNs use that as an absolute cutoff. They will not perform tubal ligations for individuals under the age of 30, or should it inform our discussion? And we have to here, when thinking about this, consider the dignity of regret. Katie Watson, our friend and colleague at Northwestern, writes beautifully about this when thinking about abortion and the kind of concerns about regret and making a decision about abortion. And this pulls from disability literature, and really needing to be able to respect that in order for people to succeed, they have to run the risk of failure, meaning in any decision, there's always a risk of regret. And if we prohibit people from making any decision based on our concerns for the risk of regret, we will not be able to empower anyone to make any decisions. And then finally, we have to interrogate our biases when we're having these discussions. Really think about, what are our prejudices and our kind of thoughts, and how are these things influencing our discussions around age, race, ethnicity, marital status, parity, sexual or gender identity, mental health. And finally, for those who really find themselves uncomfortable with these discussions, they just have to refer them to a colleague. Myself and my colleagues in complex family planning are very eager to have these discussions with these patients. They're really incredibly rewarding and deep conversations. And I've yet to have a patient who's really not able to achieve clarity and make a decision that is really sound and that we all feel very comfortable with proceeding with. And that is it. Oh, shared decision making. You guys have all talked about shared decision making, many of you. So I won't belabor this, but all of these questions should really inform a discussion that's based on shared decision making, recognizing that we are the experts when it comes to the medical information, but the patient sitting in front of us is really the expert when it comes to their values, preferences, and lived experiences. And it really has to be a discussion where all those factors are valued to come to a decision. And I think that I have 1 minute. No, I don't. I don't even have a minute. So talk to me later. Luke, we'll talk after. Okay. I did start late though, to be fair. So I think I made it just a bit under 2 minutes, or 20 minutes. So our next speaker, is this right? Is this order? Okay. Preston Reynolds. Right. Yeah. Okay. I just want to make sure our order hasn't changed. We'll be speaking about reconceptualizing professionalism to meet the needs of 21st century healthcare professionals. Preston Reynolds is professor of medicine at the University. Pardon?
That's okay.
You sure? Okay, you want to do your own intro? UVA. Thank you.
Mark. So I had the privilege of, let me make sure I know how to move forward. Okay, yeah. I had the privilege of chairing SGIM's committee to select the first Lifetime Achievement Award in clinical ethics. That's the Society of General Internal Medicine, and we were privileged to award it to Mark. And the criteria were scholarship, teaching, and mentorship. And I think if all of us have experienced his profound impact on our own lives, and as we've heard from our other speakers, his also profound impact in the scholarship and the teaching. And so, again, my personal congratulations. You weren't able there to be in person, so I wanted to really honor your award and say it was just an incredible privilege to be able to chair that committee. So I'm an internist. I'm a historian. I also work in the space of professionalism. I finished as president of the Academy for Professionalism in Healthcare, and now I lead a nationally faculty development program on professionalism. We have people from 6 countries around the world. And over the course of my life as a historian, my life as an educator, and now my work over the last 30, 40 years in professionalism, this is a synthesis talk, and it's hard for me to give. I write about it, I teach about it, but it's probably the first time I've ever actually spoken about what I teach. Events over the past several years, such as a global outcry over racial injustices and a COVID-19 pandemic of unprecedented proportions, thrust upon academic health centers demands by its students and health professionals for a more inclusive learning environment and participation in a more equitable healthcare delivery system. Within the realm of global health, leaders from around the world have reshaped a global ethic with new definitions of standard of care, Peter Singer, Sally Benatar, and a call for fulfillment of health and access to healthcare as foundational human rights. Our students today live in really complex worlds that are much more complex than when I trained, and they face really complex challenges. Many of them we've really struggled with over the last 2 days. And in listening to them, I think they're calling for a new professionalism, one that is away from our notions of privilege and one toward ideas of transformation and belonging. So I'd like to just start by asking the question, how did we get to a professionalism of privilege? So medicine in all parts of the world developed alongside the slave trade. And this book by Craig Wilder is really brilliant. It describes the impact of colonialism and the slave trade on giving birth to higher education in America and in other parts of the world, but also fueling and funding the rise of medical education and medical research. And so we see that, in fact, colonialism and the slave trade actually fostered scientific racism that then fostered structural discrimination in every aspect of organized medicine and the delivery of healthcare, not only here, but throughout the world. The other book by Michael Bird and Linda Clayton, it's a 2-volume work. Each volume is about 800 pages. This is the most brilliant piece of scholarship I could recommend to you. And they really trace the history of scientific racism back to Plato and Aristotle with the great chain of beings, with Blacks being on the bottom of that hierarchy. And that framework continuing through the Greco-Roman world, the Middle Ages, the Renaissance, the Enlightenment, and I would argue into the present. When we talk about structural racism, we're referring to the laws and policies that maintained a system of oppression. And it's a system of oppression against minority persons, and we know them as African Americans, Native Americans, indigenous persons in other parts of the world, immigrants, ethnic and religious minorities, such as Catholics, Jews, Muslims, from antiquity to the present. And we could add to that list the elderly, socioeconomic disadvantaged, disabled, LGBTQ, and the un- and undereducated. And I would argue that the application of Jim Crow racism in American medicine and its denial of access to minorities fueled the creation of actually a completely parallel system of hospitals, Black hospitals. And inside those hospitals emerged training programs for Black nurses. It also fostered separate health profession schools. And we know that the only ones that survived the Flexner Report were Howard and Meharry. It also fueled the creation of separate professional organizations that really were designed to meet the health needs of minority persons and the professional needs of minority physicians, dentists, nurses, and pharmacists. And this structural framework of oppression actually was not legally reversed until 1965 with the passage of Medicare. And it lingered inside the academy for easily another 2 decades. I gave a paper at Cornell about racial integration of hospital under Medicare in the late 1980s. And senior faculty member got up and said, well, we really didn't racially integrate here until the late 1980s when our new hospital tower opened up. So vestiges and impacts of these historic practices and lived experiences of discrimination of hundreds of thousands of patients and their generational families, I don't think can be understated. And I think they continue to live in the decisions that our patients make. And yet a pervasive silence exists on teaching this history to our current health profession students. And unfortunately, they are left to grapple with the consequences of, I would call, a system of oppression. I think we have to ask the question, why the silence? Well, I think that the professionalization of all health profession disciplines occurred during the era of Jim Crow from the 1890s to the 1930s, with creation of systems of licensure, accreditation, specialty certification, and expansion of organized medicine that was controlled exclusively by white men. And when Flexner did his report and he traveled through all the medical schools in North America, he writes about them, but not once does he comment about the Black wards in basements, attics, separate buildings, all over the structure of what emerged as academic medicine. And the impact we now know is that most of those Black medical schools closed because Flexner only supported the continuation of 2 of them. And inside those 2 emerged Black nursing schools, Black dental schools, Black schools of pharmacy. So this period of American history also witnessed a national eugenics movement, with integration of eugenics education into medical school curricula as a way to perpetuate race science. And the teaching within the academy that Blacks were biologically inferior. And this was taught as absolutely objective science. National and state eugenics laws supporting sterilization, immigration restriction, anti-miscegenation were intended to keep America white, and I would argue American medicine white. These laws codified oppression inside the medical profession, with many physicians arguing for a restriction of civil and political freedoms and denial of essential medical treatments to poor, illiterate, and minority persons. And I would argue that the outcome was white medical supremacy. Is this history reflected in our professionalism of privilege? Should we be surprised that our health profession schools today have really failed to racially integrate, that our faculty and professional organizations remain predominantly white, and that our minority patients, learners, teachers continue to experience bias and differential access to healthcare and educational opportunities and advancement? And I would ask ourselves to think whether or not our failure to end medical supremacy is actually white medical fragility. I've read and reread Robin DiAngelo's book, and every time I read it, I see medicine in those words, in the same hesitation to grapple with the reparative work that we all need to do. We know the impact of learning environments that remain hostile to the outsider. These quotes come from students at UVA. They were included in a letter to the administration in the summer of 2020 and could be replicated in schools all over the country. I was told that my iris was too dark to perform an ophthalmologic exam and that students shouldn't have to practice exams on a Black person. They take our pictures to show how diverse UVA is without actively teaching our classmates how to support minorities or our history of Black health professionals. That student took my class as an undergrad. Furthermore, these data about the impact of learning environments that fail to create a sense of belonging reveal not only the immediate impact of oppression on learners' professional formation, but the limited potential to retain diverse faculty within the academy. And these are just two really outstanding articles, one published in 2021, the other in 2020. Our faculty resist engaging in discussions about white privilege or racism. And I would argue that in failing to engage in reparative work, we are maintaining a professionalism of privilege. Our frameworks for professional ethics focus on mastery of rules and expectations and the values of an elite moral profession. And that morality can now be measured in how you increase your moral development through the professional formation identity questionnaire. And I think that these frameworks of privilege shaping this professional formation not only start with students, but actually continue throughout the training process and into our faculty. We are told, we are socialized into believing that it's a privilege to become a doctor, that we are entering an honorable profession that has expectations that must be fulfilled. But what are those privileges? How can we unpack the backpack that we wear every day? Well, let's think, what are some of these? We wear white coats with attention to grooming, proper language, systems of hierarchy. We expect to be paid well, live in large homes, in safe, segregated neighborhoods, and drive expensive cars. We expect to be able to balance work and family, work in the outside world. We believe that we practice our profession without external regulation or much regulation, and that we expect our patients to come to us with appreciation of what we have to offer. And if you watch Unnatural Causes, which is a phenomenal documentary, this ability to maintain control actually is the privilege that is associated with white privilege. What is the hidden curriculum within these expectations? Does this hidden curriculum exist to maintain white medical privilege? And does the framing of illness with the language of a biomedical model in a technological world keep the other, so many of our patients and our minority learners, oppressed? So for the last 15 years, as I said earlier in the discussion, I've had the privilege to teach an undergraduate and medical school courses on global health and human rights, and the history of African-American health professionals and their contributions to reducing health disparities and to racially integrating medicine writ large. And what I have learned in these 15 years of dialogue with students and health professions trainees really moves me now to call for a reimagined professionalism. First, learning the truth about American medicine, nursing, dentistry with their histories of oppression and racism against minorities and the other is actually incredibly liberating for these students. They become inspired by the way former generations of Black and Brown health professionals reshaped healthcare and health professions educating and made what many students describe as heroic and transformative contributions. This history teaches them to be liberators through dialogue, activism, collaborative and organized collective effort, and to understand that the ways change happen is an ebb and a flow. 2 steps forward, 1 step back, 3 steps forward, 2 steps back, 2 steps forward, 1 step back. They learn to overcome through this narrative discouragement that they might face in the future. Those who are undergrad students aspiring to become doctors, nurses, dentists, and veterinarians see more clearly the challenges they face in what still remains predominantly white space of health professions education. They go in knowing the world perhaps more honestly and less romantically. They understand why they have to work harder, appear more dedicated. They have generations of people who open the doors that they can now walk through. And at the end of the semester, nearly all of them share that they now see their role as serving others, moving beyond the privilege of social position, income, and future affluence. My 2-week medical course on global health and human rights consistently changes students' understanding of their roles in both medicine and global world. In 10 years, only a handful of students have ever heard about human rights, and none have understood how human rights has reshaped global health ethics and global health itself. We immerse ourselves in the origins of human rights and the description of over 10 human rights covenants, conventions, and treaties that embed the right to health and the right to access healthcare as foundational human rights. We discuss how all the social determinants of health are found within global health declarations: the right to education, to safe work, a living wage, to housing, food, potable water, to political, cultural, and social engagement, to religious freedom, and to protection against violence and inhumane treatment. We dialogue about how these covenants and conventions shaped the UN Millennium Goals, the UN Sustainability Goals, WHO's Commission on the Social Determinants of Health, and the more recent global movement on access to healthcare and health insurance. Then we explore the impact of climate change and climate migration and look at the Convention on Refugees. We review declarations that merge human rights and bioethics, that embrace human rights and sustainability, that incorporate foundational human rights into guidelines for human subject research. And I believe that students today want a professionalism that is liberating, not one that oppresses, with rigid expectations and marginalizes the other, whether other is a minority health professional or a patient from another culture, another socioeconomic class, or another part of the world. Before we finish our class, I asked them to design a new global ethic and a reimagined professionalism. Every single class has struggled with including the 4 principles. And instead, they identify solidarity, respect for cultural diversity, achieving health equity, ending racism and class, fulfilling human rights, environmental protection with sustainability of all life. So are these students, the canaries in the coal mine, asking for a professionalism that is grounded in human flourishing, that acknowledges intersectionality and fosters belonging, well-being, equity, that honors relationships over productivity and technology, and that uses its privilege to create a sustainable world? Thank you.
1 minute. I was not worried actually for your timing because you are a professor who teaches in the classroom. So I expected that you'd be able to speak to them. We have 1 minute for questions. That was an incredible talk. Thank you so much. Dr. Testa. Oh, I'm sorry. Would you mind speaking here? Otherwise, no one's going to be able to hear you. Sorry.
So I'm a proponent of reparations, and I actually think that the damage that the medical profession has levied on populations around the world demands that we be part of that reparative process. And that we have sterilized over 80,000 people in America. We have shortened the lives of hundreds of thousands. We have deliberately denied access and necessary treatments under objective scientific racism. I think we owe communities of color, indigenous populations, the disabled and others, reparative justice, and giving up some of our wealth in order to restore the equity that we all know is absolutely essential to human flourishing.
Dr. Testa, I hope you don't go home because you're the next speaker. Dr. Testa, graduate from the University of Padova in Italy, completed his general surgery residency both at the University of Padova and then at the University of Chicago, and fellowship in abdominal organ transplantation at Baylor in Dallas.
Can I pull it, Preston?
Pardon?
Can I pull it, Preston?
Well, yeah, sure. Okay. I do want to say though, my favorite part of
Don't say
your,
that. Are you pulling no, go ahead.
I'm not going to say the whole thing.
No.
But I am going to say that he's also a founding member of the International Society of Uterus Transplantation and the United States Uterus Transplant Consortium, which I am so excited to talk to you about, but not right now. Thank you.
Thank you. So there is a disclaimer and also is a spoiler alert for what I'm going to say is that I'm turning 60 next week. But I've had the privilege of being a scholar on Mark since I was a resident at the University of Chicago. And despite that, every time I come here, I feel like I'm still a student. I learn so much and I go home with so many ideas. So my thanks, of course, go to Mark. I hope that Peter, you'll continue this unbelievable environment to grow and foster it. And I thank everybody for all the food for thought and the fertilization of minds that happens in these 2 days. Thank you very much. So I'm going to talk about, now that this was the easy part. So I'm going to talk about donation after cardiac death. I spoke about this last year. And if you want to know something about that, the Journal of Clinical Ethics published a little piece that summarized that talk. But I'm going to touch bases on the do not resuscitate order and on the informed consent and why then we may see the right to donation, as I call it, under a different light. Why donation after cardiac death is very simple. It's become an incredible supply of organs for human transplantation, more so than we even imagined only a few years ago. To give you a simple number instead of other numbers. In my institution, more than 50% of the kidney transplant we do, and we do about 350 a year, are DCDs, and more than 30% of the 100 and more liver that we do are DCDs. So and this was not the case even 5 years ago. So this is why we're going in this direction. So for the people in the audience, the colleagues and friends who have really much knowledge about what happens during a donation after cardiac death, what happens is that a patient, as yesterday, Kosi said, medicine was powerless. So a situation in which medicine is powerless, that patient has also a do not resuscitate order. And that patient as well wants to have his life support to be drawn. And what we do happens to be also that the patient is a donor. And so we take him to surgery or wherever that withdrawal life support will happen. We extubate the patient, and then we wait until the circulatory arrest occurs. It may occur anytime, 5 minutes or 5 hours afterwards. It's just the time frame is extremely variable, and we haven't found yet a true clinical competency by which we know when this is going to happen. So it's a very unknown period. And then if the patient arrests, then we have to wait 5 minutes to make sure that the patient is really dead. And then we can start the operation of taking the orders. So this is really what happens in real life. Then there are other little details, other consideration. These processes are different in each single institution in the United States. Each single institution, University of Chicago, Christ, Northwestern has its own rule how to deal with donation after cardiac death, after circulatory death. And most of the time, pre-mortem intervention are not permitted or are looked upon in a very weird way. So from the simplest one that will be given heparin prior to the most complicated one that will be, for example, cannulation of the femoral vessel to allow rapid cooling of the organs. And then even more controversial is the issue of normothermic regional perfusion that in very lay terms means we're going to recirculate again, so practically making the heart start again pumping and recirculate the blood so that we can preserve the organs in a better way. So that's the lay of the land in terms of what we do on a daily basis. So those were my conclusion from last year, where I said that I think we need a renewed ethical approach in view of how much dominant donation after circulatory has become in the United States. And I thought that we needed a more donor-centric approach. And in this way, what I try to say is that we have to concentrate on the wish of the donor and making the organs the real trait union, so the liaison between the donor and the recipient, so giving a continuum of care and this focusing on the organ that are donated. So what are these patient and donor wishes I'm talking about? Simply said, there is a DNR organ, there is a withdrawal life support, and there is a donation. All these are based on very clear rules or regulation or dictate, whatever you want to call them. But it's clear that every hospital is going to ask you about advanced directives. It's clear that if you ask or your family asks that we withdraw support, there are physicians who are going to help you through that process, and there are very clear determination on how this process should run. And it's clear that we are asked whether we want to be donors or not, and we have this on our driver license, or we tell our spouses that, or our friends or whatever, we want to be a donor. So all this seems to be fairly straightforward. And all of this in a certain way is based on autonomy. We have been talking about autonomy, even the talks we heard now, and the fact that there is information that can be given, can be understood about how this process runs. Now, what is important is to understand also what the dead donor rule is. And it's a rule that's been created where before we can initiate any process of donation, meaning really make an incision on the donor in few words, or in certain cases, even inserting the cannula, or even giving the heparin, as I said, the donor must be dead. The patient must be dead and then become a donor. Now, the interesting part is that there is a very incredible lack of clinical evidence when somebody is really dead. Because if you think about that, Now, most of the recent literature, we talk about the process of dying. It's not anymore a distinct moment, it's a process of dying. In this process, to identify when all our brain cells are gone is impossible, and becomes even more impossible if we try to identify this moment between the extubation time and the moment that those organs are still viable. It's too short. Even if there was some gizmo, some mechanism I can find out, I cannot apply that. So this is really the problem. So we have that lack of clinical evidence. On the opposite side of the spectrum, we have a plethora, we have an abundance of ethical discussion about who's dead, how's dead, when you're dead, and all the things that go with it. And Vich, in 2003, had seen really clearly, and he points out two very interesting things. One thing he points out is that we have no knowledge, so we have to accept that. And the other thing he points out that probably we rush to have some form of rules or regulations that if we had time now and knowing what happened, we'll probably think about a different strategy. It's very important because it really sets the conversation on a different tone. And in reality, what I think happened is that we needed some form of rules that would allow the surgeon to do the job that we were doing, so taking organs from people, at the same time maintaining the trust of the public toward the profession, and at the same time also avoiding the people who were taking the organs could be called killers, which, by the way, this verb or term in donation should never be applied. I put that on purpose because I wanted to say that when we apply the verb killing in the profession of medicine, it's really the wrong approach. But unfortunately, this has become mainstream, I think. And then this ethical conversations continue. This med page, I didn't put there because it's such an important point of reference. But if you Google it and you do dead donor rule, is one of the most viewed pages that you found. So people are reading it, and clearly it comes out that, as the camp says, medicine looks out for the best interest of the patients. And I want to really point out this best interest of the patient, or the dignity of the human who donates organs should never be sacrificed. It is very important. My point, though, is we continue to see the issue, the topic, only from one side, which is the side of subconsciously or consciously thinking that we're doing something wrong by approaching donation in the way that I'm going to tell you that I should approach it. So it is true that this is a universally accepted fact that the dead donor rule looks after the universally looks after the interests of every single patient. And are we sure that violating the dead donor rule is a violation of the dignity of every single patient? And I disagree with this. So this is a profile, 60-year-old, hypertension, past medical history, drinks a martini every couple of weeks, a glass of 2 wines, failed attempt, they call it brain aneurysm. So this patient is now going to die because of the brain aneurysm, but is not brain dead. So he's a candidate for donor after circulatory death. He said and told his wife, if I die or in process of dying, I want to be a 7 organs donor. It's possible. He can donate lungs, heart, liver, kidneys, pancreas. So not too bad, right? That's his wish. That's really what he wants to do. Now the question is, what will prevent this specific patient to become a donor of 7 organs? And the only thing that will prevent it is the time that will intercur from the moment the tube is extracted from his throat to the moment that somebody will declare him dead by the fact that he has no heartbeat anymore, and then wait 5 minutes longer, and then finally initiate the process of donation. That's that's reality. This is, I explained to you the process. So what I ask, and this is an ask, is it possible to reframe this conversation and accept in a certain way the underlying cause of death is not the withdrawal of life support, is not the fact that somebody is taking the organs, but is the underlying pathological condition that brought this patient to be a patient that will become a donor. that this is the way that I would like to see. By the way, there is an article on American Journal of Bioethics by Bosch and MacLean that was published, I think, this month, that speaks about this, speaks about the reinterpretation of what we consider that the dead donor rule doesn't say that is the taking of the organs that killed the patient, is the condition that the patient had that has killed the patient. So, and interesting enough, the moment we extubate the patient is also the moment of no return, because the patient has the DNR organ. So we are not going to start pumping the heart again once the patient is dead. Also because even if we reestablish life, that patient is not going to have a meaningful life because he's going to die anyhow of his condition. So reframing for me is, if the patient, this is a very important if the patient is given consent to donation, my opinion is, as we grant him the right to DNR and the right to withdraw life support, we should grant also the wish to become a donor, to be a donor. And so at that point, I dare to say we should do anything possible. And this is a reframing also what was said yesterday by Kosic, is that in this case, medicine is not powerless. Medicine can reframe its mentality or its culture that is bad per se, and try instead to take something good from the process of dying. So interesting when you read this article by Singer, where he outlines what should we do in palliative care when we withdraw support, one of the things that comes out is avoidance of inappropriate prolongation of dying. And I can, in my opinion, that's my opinion, is that when I'm extubated, I'm going to die anyhow. If you let me die there without granting my wish, you are uselessly prolonging my process of dying. That's really what I think. So if the patient wants to be a donor, that's a big if, but that's important though, because that's a category of people that we need also to take in consideration. We don't know all the same in the way we intend death in general. So when I gave consent, I was an individual in full moral standing. And I think that I should be considered, if I'm a donor, I should consider an individual in full moral standing until my organs are taken. Then I'm dead. So this is really to me, a very important concept. So I would dare to say that as we uphold every other wish of the patient, we should also uphold the one of donation. We should also, in a certain way, let people make decisions about the way they want to die. Honestly, there's been an evolution in the ethics of all these things. I mean, when I started residency, we didn't have a palliative care, we didn't have withdrawal or support. That was only 25 years ago. And now every hospital has this. There has been an evolution. I think in this evolution, donation should play a part because it's important, because at the end of the day, it doesn't harm society and doesn't harm anybody. It's something good. And by the way, I want to rephrase this and repeat it, is the pathology that has killed the patient, is not the action of the physician that are involved in the process of dying. And this is just another quote about choosing death, but it's one of the things that we may disagree or agree upon, but I think it's become important. So this is my last slide. I approve of all the conversations that have been made about the dead donor rule. It's an important, essential conversation to have. But I would like to see an evolution of this conversation, indicating the fact that I'm not the only one in this talk. I speak to dozens of colleagues and we all think the same. No, we all think, but there are many people who think the same. So I know I'm not the only one. I happen to be a transplant surgeon, and for some of you, I happen to have a invested interest in these things. But by the way, the vignette of the clinical patient is mine. That's me. So if I'm going to be a donor, I would like to be the 7. I got hypertension, and I do drink a martini every 2 weeks. So, and yesterday, Erin said something that I wanted to add to my last slide. Does the actual ethical framework maximize life saved? And I would dare to say that that was applied to her talk, but you can apply to this talk, and they would say, no, it doesn't. And I don't think that it's that bad to initiate the conversation, even if to initiate that is an ignorant person like me, a surgeon, but I live with this every day, and I know the disaster that some family feel when the loved one goes back to the room 2 hours later without having donated. And thank you for your attention.
Want to stay for questions?
I don't know, you are.
Yeah, we have
you're the
time.
chief.
Yeah, we have three minutes for questions, actually. Thank you.
Now I know I'm in trouble.
Professor Brennan.
When the philosopher comes here, I'm powerless. Can I ask?
Thank you. Listen, that was a great talk. I agree with just about everything, but I do have this question. Do you know the book by Robert Trug and Franklin Miller on the dead donor rule?
Yes.
In which they come out exactly where you come out, but with a verbal difference. And I just wanted to hear you say more about why you disagree with them about the verbal difference. They're perfectly willing, in line with work by other people like Dan Brock, to think of the concept of a justified, morally justified killing as a way of talking about exactly what you have in mind. Reducing the amount of time between when the donor arrests and when the time that organs can be taken, so as to make it more likely that more organs can be used successfully. That's always seemed, and that sort of has seemed to me a compelling account. You want not to use that language. And I just wanted to know why. Is it entirely for the strategic reason that it won't play well with the public, or analytically, do you not think that they're right in how they describe what happens?
So I lack the eloquence to answer properly the question. But what I think simply is that if I'm the donor and I want to be a donor, I would like to have a physician who's attuned with my way of thinking and is willing to give me whatever it needs to be given to make sure that my heart arrest occurs in a short time. So shorten my, I don't think that's killing. I think that's medical intervention to allow me to be the vehicle of a continuum of care from me passing and my organs going to somebody where they're gonna.
Fair enough. But then isn't the donor still alive until the organs get extracted?
But that's a real point where we have a problem with the dead donor rule. I claim, or I would argue, that I consider myself dead the moment that somebody has decided to withdraw support from me, because that's a point of no return.
Why not just get rid of the dead donor rule instead?
Well, honestly, I didn't make it up. I mean, the donor rule has been there, but but this is important. I want to follow up a little bit on that, because for many people, that's a way of thinking. It's important. I describe a very specific patient population, which is mine, the one who think alike. So for people who want to be donors, we should probably get away from the donor rule when it's very well written that that's their wish. For other people, we should keep it, because otherwise you're going to break trust, and we think people are going to go and take organs from everybody. You're welcome.
And we are good on time. Thank you so much. Thank you. All right, we are sticking to it. Our next speaker is Richard Gunderman from Indiana University. He's the Chancellor's Professor of Radiology. This is impressive. Radiology, pediatrics, medical education, philosophy, liberal arts, philanthropy, and medical humanities and health studies at Indiana University. He's also John A. Campbell Professor of Radiology and served as bicentennial professor. He was the Chancellor Scholar of the Federal Republic of Germany and received an honorary doctorate of human letters from Garrett Theological Seminary at Northwestern. So I am thrilled to introduce Dr. Gustafson and what says Gunderman. Okay, yes, okay, sorry. Dr. Gunderman. who's going to be speaking about Master Contextualist of Medical Ethics. I'm sorry, your name was written incorrectly on my sheet of paper. Thank you so much.
Well, thanks a lot. It's a pleasure to be with you virtually, and I'm delighted to have the opportunity to speak about one of my mentors at the University of Chicago, James Gustafson, who died in January of 2021. And I'd just say a little bit about the first text I ever had an opportunity to read with Jim. When I arrived in 1983 as a new medical student, I was in the medical scientist training program. I was going to combine studies in medicine and the Committee on Social Thought. The first book Jim Gustafson gave me to read was the book of Job, which has traditionally been understood as about theodicy. How can we have evil in a world that's governed by an all good, all powerful, all knowable God? The text says Job is the greatest man in the East, blameless and upright before God, yet he loses all of his impressive property, his family, ultimately his own health, and his wife counsels him to curse God and die. This is, of course, one of William Blake's breathtaking illustrations of the text of the book of Job. And I don't want to say any more about Job right now, but I'll return to it at the end. The big question would be, is Job a text of theodicy? That is it about divine justice? So now a little bit about Jim Gustafson, who was born in 1925 in Michigan. Interestingly, his first higher education experience was at North Park Junior College. He served in World War II in Burma and India, once taking on a post in which the person who preceded him had been blown to bits on the border between Burma and China. In 1948, he earned his bachelor's degree from Northwestern. In 1951, another bachelor's, this time in divinity at Chicago. That same year, he was ordained a minister in the United Church of Christ. And in 1955, took his PhD at Yale under the supervision of H. Richard Niebuhr. So I hope this picture warms the hearts of some people attending to this lecture. It sure does mine. Gustafson joined the Yale faculty in 1955, came to Chicago in 72 as the university professor of theological ethics in the Divinity School and the Committee on Social Thought. Sadly, he left Chicago in 1988 to take on a very interesting position at Emory. But during this time, he published his magnum opus, Ethics from a Theocentric Perspective, the first volume released in 81 and the second one in 84. And I had the privilege of being a student at Chicago and seeing him on a quite regular basis between 1983 when I arrived and 1988 when he departed. And you know, the books we read are important, but the people with whom we have the privilege of reading them, I think, is an equally important key in the door of the pursuit of knowledge. So Gustafson loved to talk about context. His masterwork, Ethics from a Theocentric Perspective, quotes from Milton, "So little knows any but God alone to value right the good things before him." From Milton's point of view and Gustafson's as well, one of our principal challenges is the fact that we're unable to appreciate the full worth of the things and in particular the people we encounter in life. I want to tell you a story from Victoria Sweet's book, God's Hotel, which I hope all of us are familiar with. It's the story of a head nurse who went and knits at Laguna Honda Hospital, the nation's last almshouse, perhaps, in San Francisco. This head nurse who knits blankets. And the author becomes aware of this when she sees elderly women seated in wheelchairs outside their unit, wrapped in beautiful hand-knitted blankets. These blankets let not only the people at the hospital, but everyone else know that their mothers and great aunts and sisters are being very well cared for. Well, the hospital hires some consultants who are going to help it increase efficiency and reduce costs. These consultants are from a well-known business consulting firm with the D. And these consultants, of course, arrive with clipboards and Microsoft Excel spreadsheets and quickly determine that the head nurse who knits isn't contributing much value to the organization. But soon after the head nurse is reassigned in the unit, the numbers of injuries, disabilities, and early retirements among the staff skyrocket, as do the number of falls and bed sores and tears shed at work among both patients and staff. I think this is a very important story that our Excel spreadsheets, our data, our metrics often don't tell us the whole story. And quoting from Jim Gustafson, Gustafson reminds us there's never only one outcome of human action because we are joined together in interdependence. The consultants from D&T may be able to increase efficiency and reduce costs, but they also take a tremendous toll on the time and mental attention necessary to care. And Gustafson reminds us to be careful. If we believe we're the center of value in our little world, others become simply means for our interests and desires, tools for our achievements, objects whose own place in the scheme of things is denied by reducing them to their utility value to us. So the key word that is in that sentence is, of course, context. So from Gustafson's point of view, is to see ourselves from a theocentric, that is God-centered perspective, is to see and feel ourselves in a condition of ambiguity, because of course we are not God. I think the single principle that Jim Gustafson implanted in me more than anything else, we are not God. And this condition of ambiguity can't be totally relieved by constructing an ideal ethical theory that provides certainty. In other words, uncertainty may be endemic within medicine, and the effort to relieve it may in fact be a turning away from the light rather than the addition of additional clarity. So, of course, Jim Gustafson was a Christian, and he said the Gospels portray Jesus as one who incarnates in his teaching, manner, and actions, theocentric piety and fidelity, a challenge to all of us. Some may not be theocentric, some may be anthropocentric or otherwise, but what do we incarnate in our teachings and manner and actions? So the next story I want to share with you briefly is about my wife. We got married right before we came to Chicago. I to start medical school, she to work on the oncology unit, which was then 5 Northeast. And over the years she worked there, she complained bitterly that she was spending more and more time documenting the care she delivered to her patients and less time actually caring for her patients face-to-face and hands-on. In fact, one night she worked the evening shift. The shift ended at 11:30. She would often get back at 1 a.m. or 1:30 a.m. I'd walk down to the emergency room to escort her back to our apartment in the now demolished Femister Hall. But she complained that she didn't have time anymore to rub her patients' backs. Now, you don't go to nursing school or medical school to learn to rub backs. But on the other hand, I think most of us can appreciate that's one of our best opportunities to really connect with our patients. It gets us to reconsider what's just ancillary and what's essential in our work. So Gustafson said, don't do anything that's unhelpful, that doesn't build up community, that seeks our own good in preference to that of a neighbor, that violates our own conscience, that violates the consciences of others, that is deliberately offensive to other groups, and that is not worthy of the imitation of Christ. You know, we reconstructed the work of our registered nurses in a way that made contact with their patients, the healing power of touch, at least more difficult and in some cases impossible. Jim said we need to think about how parts are related to wholes. That's particularly important in grounding the presumption of values and principles. We're part of an independent ordering of nature, parts of institutions. In other words, we have to see ourselves in those contexts and recognize that the collective good doesn't always override the claims of individuals, like the deeply laudable and noble desire of nurses to be able to lay hands on their patients. So the last story I want to tell is about Max, which I got from a colleague out in California, Gene Dorio. Max was an 80-year-old man brought into the emergency department with a femur fracture. He was disheveled and speaking gibberish, was determined to be homeless. And after his fracture was splinted, he was being readied for transfer. But a couple of hours later, a nurse burst into the room and said, "Hey, he's speaking English. He says his name is Max. He gave us his phone number." So the physician called, and the woman who answered the phone said, "That's my Max." 10 minutes later, a car screeched to a halt just outside the emergency room, and out of the back seat of the Rolls Royce that bore the license plate, Mrs. Max, climbed a lady in a fur coat, and the transfer was canceled. Now, that's not exactly a Gustafsonian story, but it shows how a little shift in context can dramatically change how we see the patient. And Jim was always at pains to say that our primary function, at least insofar as we're ethicists, isn't to prescribe choices, but to enable those involved to make more informed choices. That our function is to broaden and deepen the capacities of others to make morally responsible choices, and that a community of moral discourse allows different points of view to be exposed. Said Gustafson, we must avoid a conception of a God we can manage, a God who comes when beckoned, a God who permits us to say that he's here but not there, who supports our moral cause, a household God who cares more for us and ours than others who will suffer like we suffer. Jim said we must remember our ultimate dependence on a power that we can't control and a source of goodness we did not and cannot create. So we come back to the book of Job, which I at least had always been taught to read as a text on theodicy, divine justice. Job is the greatest man in all the East, blameless and upright before God. How in the world could he justly lose his property, his family, and his health? Why shouldn't he take his wife's advice to curse God and die? This is from the 38th chapter of the book of Job. These are the Lord's words out of the whirlwind. Who darkens counsel by words without knowledge? Gird now your loins like a man, for I will ask and you will answer. Where were you when I laid the foundations of the earth? Say if you have understanding. Who laid the measures of it, if you know? Who laid its cornerstone when the morning stars sang together and all the sons of God shouted for joy? Job thought the problem was justice, but Jim Gustafson points us to a different problem in the book of Job, in our lives, and in clinical ethics, namely the problem, which is also an opportunity, of finitude. Said Jim, to alter the place of value that the human has had in much of ethical thought and human activity is not to say that ethics isn't addressed to human beings as creatures who have the capacity to act. To say that human beings are part of a whole that is governed by the divine ordering is not to demean the importance of human activity and the practical importance of ethics. The task, however, says Jim Gustafson, pastor, theologian, and from my point of view, a truly remarkable human being. The task, however, is to serve God. Human values are set in the context of more inclusive divine purposes. So I hope those words ring true to you, or at least have an evocative or provocative effect, because I think God is sometimes absent to an excessive extent from our discussions of ethics. And I feel very loyal to Jim Gustafson as somebody who repeatedly drew our attention to the divine, or as he would say, theocentric perspective on ethics. That's the context in which ethics at its best needs to be done. Thank you very much.
Excuse me. Thank you very much for that thought-provoking talk. Do we have any questions in the audience? Dr. Siegler? Probably not. I'll repeat the question. Oh, we're getting a mic. We have about 3 minutes.
Richard, hi, it's Mark Siegler. Lovely to see you. And your talk was very moving and superb. I just wanted to say something about Jim Gustafson, who, as you say, arrived on the campus from Yale in 1972. I joined the faculty in 1972 also. They had sent me off to England for a year, and I came back. And within the first month, Jim Gustafson took me on once a week to work with me on my clinical medical ethics program that I had started in 1972. Now, Jim at Yale had been essentially the founder or the major program developer of bioethics, which started in the United States around 64 or 65. And Jim had trained roughly half of the first generation of bioethicists at Yale before he moved to Chicago. And then he worked with me on clinical medical ethics. And 2 years after he arrived and I arrived, we got an NIH grant on clinical medical ethics, which was a modification of bioethics. So, and I thought the world of him. And when you came along, he was spectacular as always. But thank you so much for that beautiful talk.
Dr. Siegler. I think we are going to move on to our next speaker, Valerie Gutman-Koch. I'm just going to say a couple things. She is the Director of Law and Ethics at the MacLean Center. And that's what we're going to say. And I am going to say one other thing, and that is that the title of her talk has changed. And she is, instead of the original talk, going to be talking about reimagining informed consent from disclosure to comprehension. I'm very excited to hear this.
Oh, I was trying to put a timer on, but that did not work. Okay, never mind. Thank you. Hi, thank you all so much for sticking around, for having me. I'm so happy to be here. I was inspired to change the subject of my talk today, primarily after listening to all the amazing talks about how do we fix informed consent. There's been a lot of conversation about that today. And in some ways, my decision was a bit selfish. It's a very early stage project, and I really want everybody's feedback, especially those who are such experts in this area and are thinking so deeply around these issues. That said, this is my new project. So I'm going to start with a brief statement, of course, of what are the ethical, that's normal. This is sort of what I'm doing here. I'm going to talk a little bit about the history, go through why the law doesn't do what it's supposed to do, or at least it says it's going to do, propose a change on how we can fix it, and then start to think about some of the kind of underlying other issues that would relate to this proposal. So I'll start with the ethics. So this is the AMA definition of informed consent that I'm sure all of you have seen before. It talks about it being a process rather than a form. And so the ethical conception of informed consent to evolve to ensure this patient self-determination and voluntary decision-making. And it's premised on the notion that patients don't relinquish their rights when they enter a hospital or a physician's office. And it's intended to foster trust in the doctor-patient relationship. So we have this list that I think many of us have sort of discussed in the past, the various purposes, goals of the ethical doctrine of informed consent. And as I move through this talk, I want us to think about whether our laws, whether our current approach to the legal doctrine of informed consent actually furthers these purposes. So the legal doctrine of informed consent evolved then to serve those ethical goals, the goals of ensuring autonomous, voluntary, and informed decision-making in medicine. And it represents, the legal doctrine, one of the most widely accepted efforts to encapsulate ethical principles into law. And so as many first-year law students can tell you, at least I hope my tort law students can tell you, a claim for a lack of informed consent requires the same elements that are required to establish a traditional negligence claim. And the first is this duty, the duty of care. Here it's a duty of disclosure that I'm highlighting here, and we're going to come back to this slide in a moment. But since the introduction of the legal doctrine of informed consent, the Canterbury decision was in 1972, but we saw the first introduction of the notion of informed consent in the law in the late 1950s and early 1960s. Since then, attempts to improve the law to better track those ethical goals underlying it have focused on what physicians need to disclose to patients. So attempts to tweak or modify or overhaul these disclosures didn't end with the introduction of the reasonable person standard that we saw in the seminal 1972 decision of Canterbury versus Spence. And that was, incidentally, 50 years ago this year. So there have been many other efforts to expand the disclosure requirements. In 1991, a Louisiana appellate court held that a surgeon's history of alcohol use was relevant to the informed consent process. In 1993, a Maryland court held that the HIV positive status of a physician may be material to a physician's decision, patient's decision to undergo surgery, because the court said it was foreseeable that the physician might transfer or transmit the AIDS virus to his patients. And in 1996, a decision that was eventually overturned by the state legislature, but has scared a lot of other states, the Wisconsin Supreme Court held that a surgeon had an obligation to disclose his relative inexperience in a particular surgical intervention to his patient. So despite these various modifications and expansions to the disclosure requirements of informed consent, there's little evidence that the process has improved patient understanding. And in fact, as long as the legal doctrine of informed consent has existed, so too have arguments that it's ineffective in protecting patient self-determination. So here's a litany of some very well-known and respected scholars in their various opinions about the legal doctrine of informed consent. It's been called a superficial charade rather than an autonomous choice. A charade is symbolic, but contentless formality, and the bête noire of the medical malpractice doctrine. So in other words, it's argued that the informed consent process in the medical context has been co-opted by the legal community in an effort to protect healthcare providers from liability, and it does not, in fact, serve those lofty goals of ensuring a robust process to protect patient decisions by guaranteeing that their treatment decisions are voluntary and informed. So why is this? Well, instead of focusing on informing patients and ensuring patient self-determination, the principles upon which Canterbury and other decisions were presumably based, the practice of obtaining informed consent to treatment is as we've seen, preoccupied by physician disclosures, both in documents, as we've seen earlier today with Alex's talk, and in conversations. And in most cases, with the intent of the CYA language that Alex used earlier, the intention of shielding healthcare providers from litigation. And the legal doctrines focus on the legal adequacy of physician disclosures, emphasizes ritual over relationship. It's both needlessly adversarial and backward-looking, leading physicians to assume more disclosure is better for the purposes of preventing liability. In effect, the law's onerous legal requirements necessitate over-disclosure at the expense of patient understanding, rendering the legal doctrine ineffective at actually informed voluntary decision-making. So as we've also seen earlier today, informed consent in treatment often focuses again less on process and more on this documentation, the signing of a form. And it's widely understood that these forms, again, as we've seen from so many wonderful scholars today, are often unintelligible and increasingly lengthy, such that the average patient would be unable to fully understand the potential risks and benefits of the proposed intervention. Informed consent forms are notoriously unreadable, often providing information required under the law without considering the usefulness of these forms in increasing patient comprehension. So this is an example that, thanks to Twitter, I don't know how much longer I'll be able to pull things from there, but this is an example of an informed consent form to treatment from 1954. And these, of course, are just the first pages of surgical consent forms that I found online today. So due to the law's emphasis on disclosures, often to the point, again, of over-disclosure, we have lost sight of those original ethical goals. And the law certainly does not make patient decision-making any easier. So I've set out to fix the law by making it better reflect the ethical goals that underlie it. So using Daniel Golden's language from earlier, the law isn't currently furthering the use of informed consent in its adjective form, and I'm looking to try to fix that as well. This is just a beautiful quote that I love from Professor Charity Scott, talking about how when we focus on the law, we tend to lose sight of the ethical underpinnings for it. In trying to focus on the letter of the law, we often lose sight of its spirit. When law becomes pervasive, we often forget about the original ethical questions that prompted the legal resolutions. So I'm trying to bring us back. So evidence indicates that pre-therapeutic understanding is already quite low. Even when information is shared, recall isn't very good. In one study of almost 100 patients scheduled for elective orthopedic surgery, researchers found that, quote, patient comprehension and recall immediately following a thorough discussion of the consent form was unexpectedly low. Another study showed patient recall of risks to be at 26.5%, only 20 minutes after the informed consent process. In another study, investigators found that the average patient only recalled 18% of disclosed risks of a particular intervention. And in a study on informed consent for cataract surgery, despite preoperative discussion and written information, 61% of patients did not know what a cataract was, yet they consented to the cataract surgery. 43% misunderstood that surgery was completely risk-free. So despite the fact that the legal doctrine of informed consent is one of the most, as I mentioned earlier, widely accepted ethical approaches to encapsulate ethical principles into law, studies have consistently shown that the results of efforts to increase patient understanding and self-determination are disappointing. So today, I'm not attempting to then reassess what needs to be disclosed. As I've hopefully already convinced you, or started to convince you at least, this has been the sole focus of what I think are pretty ineffective efforts to fix the legal doctrine of informed consent. Rather, I'm proposing a shift away from the exclusive focus on physician disclosures towards a standard that emphasizes patient comprehension in order to realize the ethical promise of informed consent by ensuring that patients' decisions are voluntary and autonomous. In other words, we should craft a right of action that underscores the duty to obtain consent to treatment. And this proposal, therefore, shifts the emphasis away from mandated disclosures to a system of disclosures and comprehension. Building this comprehension element into the question of whether the physician satisfied their duty of care will allow the law to better reflect the ethical values of the doctrine of informed consent and the shared decision-making model. So importantly, this proposal isn't trying to eliminate disclosures. There should still be mandated disclosures. Physicians still need to tell the patients about the risks, benefits, and alternatives of the proposed intervention. And so it would maintain this objective standard. Instead, this proposal, my proposal, argues that legal rules should reject the singular focus on the clinician's affirmative duty, and it adds a duty. In other words, the plaintiff herself did not understand the risk, benefits, and alternatives of the proposed intervention, then the physician has breached their duty. So medicine and ethics scholars have advocated for a new comprehension-based standard that better reflects the ethical principles of informed consent. But this shift, I think, today is actually feasible from a legal perspective. Establishing a subjective rule for comprehension that looks to the individual patient's understanding respects the fact that patient preferences are personal and maybe idiosyncratic. No matter what the outcome, it's the patient that bears the burden. So as we continue to study and learn how to assess comprehension, we can start to look at the patient then to determine whether she's comprehended based on the disclosures that have been provided. Legal standards for assessing patient comprehension during the informed consent process will need to constantly evolve to reflect progress in the development of verified tools based on empirical research. And so some of these tools include patient decision aids, incorporating technology into the informed consent process, repeat back or teach back techniques, and Dr. Swarzi's best case, worst case approach. And there are more that were even proposed today that I did not have time to add to the slide. So as I think about the best approach to this proposal, I do have a few additional thoughts that will hopefully lend themselves to further analysis. So first, and incredibly important, I think, is that since investigators began analyzing the sufficiency of informed consent, it's been recognized that age, race, and education were associated with the degree of comprehension. And so we'll continue to see inconsistent health literacy, language barriers, and racial inequities in the medical system. And it remains today a reality that poor informed consent disparately impacts certain populations, such as those with limited English proficiency and poor health or medical literacy. Perhaps, I'm trying to be optimistic here, my proposal can help to achieve some greater level of understanding and shift the emphasis from disclosures to disclosure and comprehension in order to align the ethical goals of informed consent with the legal rules that govern it. And perhaps by shifting to that more subjective approach, we can begin not only to align the law with ethics, but also to ameliorate some of the inequities that are endemic to the informed consent process. Also, this proposal is not a natural extension of common law principles of organic developments in informed consent law. So as methods for assessing and ensuring patient comprehension during the informed consent process become more effective, state legislatures should amend their rules for determining whether a patient has a valid claim for informed consent to medical treatment. So this might require a legislative fix. And finally, In order to ensure that patients are afforded the appropriate time and resources to ensure comprehension of the risks of a proposed intervention, this proposal may also require a re-examination of other rules around informed consent. And in particular, we might want to think about rethinking the legal requirement that only physicians in many states, only physicians may obtain a patient's informed consent. So it's worth considering designating, say, an informed consent ombudsman or a committee to whom the patient can go whenever a question or concern arises. This might help with resource allocation. There's always concerns that, of course, the informed consent conversation is generally not compensated, that physicians are already spread thin, and adding this extra expectation of now assessing and ensuring comprehension will not only increase the burden on physicians. And so allowing delegation of informed consent and that process would hopefully ameliorate that to some extent. But of course, I continue to argue that those conversations should be compensated. So with this proposal, hopefully the law can better reflect the ethical goals that underpin the doctrine of informed consent. And while this may require a major cultural change, it will better encourage information exchange and deliberation in the medical decision-making process, while continuing to reflect patient autonomy and uphold patient dignity. Thank you. As usual, I'm the only law professor I think that goes under time.
2 minutes for question.
Thank you so much. It boggles my mind that you decided to switch your topic at lunchtime. It's this good. Thank you. Thank you for giving this talk. I would wonder how you think is the best way to measure whether or not the patient understands. And is this something that happens immediately after the conversation? Is this something that's only assessed if it gets to the court for some reason? And how can we standardize that such that it's reliable, but not super time consuming, as you're saying, given sort of the constraints of the clinic environment?
Absolutely. And so, I think we're at this kind of crucial moment in time where we're 50 years after Canterbury. I firmly think that it's not working the way we have it right now, but we are also now finally starting to develop these validated tools for assessing and measuring comprehension. And so it's still somewhat in its infancy. So I do think this is like a long-term process that I'm proposing, not a fix that happens tomorrow. That said, as far as comprehension assessments go, I do think they do have to be in the moment. And they probably will, for better or worse, have to be documented to some extent, just like informed consent does. But I'm hoping that we can do it in a way that isn't just, again, a CYA endeavor, but a way to ensure that those conversations are happening, perhaps with the various tools that I've heard discussed throughout the last 2 days and others that are being developed. I don't advocate for having these conversations in an ex post kind of way in the courtroom, because hindsight is always 20/20. And so anybody who feels like they've been injured would just argue that they didn't understand.
But that's where these conversations are going to happen.
Well, trying to fix it.
Yeah, I know, but like this is where it comes up, right?
Mhm. Yeah.
Thank you so much,
All right.
Valerie.
Thank you.
All right.
And our last speaker is Professor Harold Pollack. As he walks, I think I actually have time to do his bio. The Helen Ross Professor at the Crown Family School of Social Work, Policy and Practice, which will forever be SSA to me. He's also an affiliate professor of the Biological Sciences Collegiate Division, Department of Public Health Sciences. Additionally, co-founder of the University of Chicago Crime Lab. I'm going to stop there, but I also would like to say that it's great to have Professor Pollack be our last speaker. I've had the pleasure, I don't know if you remember this, he was very generous, allowed me to sit in on one of his courses, and he's an incredibly engaging speaker. So this is a great way to end the series of speakers. So thank you very much.
Boy, no pressure on that. let's see, I just realized I don't even know how to advance the slides now.
That's the little green button.
Oh, the green
The
button.
big button.
I have a bachelor's degree in electrical engineering and I can't figure out how to advance the slides. So by the way, it's such an honor to be here to honor Mark who is just one of my role models and heroes. I want to talk today. I must say my talk is much less conceptually sophisticated than most of the talks that have come today. It's really a report in the field from someone doing a public health intervention trial, and a little bit about a raging debate in my own head about how we do an ethically defensible and publicly legitimate randomized trial in the middle of an agonizing epidemic. I mean, and so I want to talk about the ethics, the stakeholder and public legitimacy of doing that. COVID is the worst public health crisis we've experienced in a generation. In terms of cumulative mortality, I would include COVID in that assessment. I mean, we're losing 85,000 dead a year from opioid overdose. And under any feasible policy, we're going to lose tens of thousands of people every year for the foreseeable future. And everybody myself and everybody that is in this field, we know so many people who have been beautiful people who've been lost to opioid overdose. And it really challenges us when we think about doing a randomized trial, because it's so important to generate the kind of scientifically rigorous evidence that only a randomized trial can give us, but to do that in a way that honors the humanity of every person. And that's really what we've been struggling with in our study. So here's my roadmap over the next 3 hours. I'll say a little bit about the landscape of the opioid epidemic and the sense of moral injury and the crisis of legitimacy among our staff and our stakeholders when you come into that epidemic and you say, we have this beautiful randomized trial we want to do. And how we approach some of those dilemmas in a big trial we're doing called Reducing Opioid Mortality in Illinois, ROMI, and why we don't have a control or usual care group, and why I'm trying very hard in my studies never to have a control or usual care group when we're dealing with an issue of this sort, and some of the benefits and costs that we've experienced in doing that when we're doing studies that involve profoundly vulnerable populations facing such a life-threatening situation. And one of the ironies is that our decision not to have a usual care control group actually rescued our study. And I'll mention that later. And how those of us that do intervention trials really have to think in a deep way, how do we honor the humanity and protect the essential interests of every study participant? And I don't mean what the IRB will accept or demand. I mean, part of the study design from day one, what can we do that is scientifically valuable and credible and workable, but that really helps everybody, that honors us, everyone who honors us by sharing their data with us, by joining our studies. And the necessity and the limitations of randomized trials in this context when we're trying to understand treatment and harm reduction interventions, in this very difficult situation. So you can see why my talk is 3 hours. Okay. So I don't think in this group I have to go into a lot of detail, but it's almost impossible to convey the scale of the carnage from opioids. More than 80,000 Americans died last year of opioid-involved overdoses. Of course, fentanyl and synthetic opioids are playing a huge role and have really come to dominate mortality. And so I have just never seen something that looks an exponential curve for a public health catastrophe like this, in my career. I mean, that is just astonishing, how bad it is. And so, that's the context in which we are operating. And everyone that we work with is experiencing on a routine basis fatal overdoses, profound tragedies that are really that are almost impossible to describe. Now, I should say there are some positives in this too. One of the most positive is that there really is a bipartisan sense of alarm and collaboration in how to deal with this crisis. And one of the striking things in my career was the Bush, Obama, Trump, and Biden administrations have all been surprisingly normal and collaborative in trying to deal with this crisis. And, President Bush supported mental health parity. When the Affordable Care Act was debated in the United States Senate, the Senate Finance Committee was voting on it. And all the Republicans who voted against the Affordable Care Act, they unanimously voted for all the behavioral health components of the Affordable Care Act. Many of us, I was an advocate for the ACA. Many of us thought there would be a kind of Willie Horton politics that would come out of the ACA, that, somebody who was getting addiction services under Medicaid would stab a nurse, and then we would have lots of political ads that were sort of Willie Horton style. And that has not happened. And it's really quite interesting. President Trump spoke quite humanely on the campaign trail in 2016 about the opiate epidemic. And it was a factor in him winning Ohio and some other states. And we see lots of legislative initiatives that Democrats and Republicans have supported, including I went to a meeting where Kellyanne Conway was sort of the lead speaker, and she was talking about how everyone needs to get into evidence-based treatment. And, that was not what many of my progressive Crown students would have expected her to be saying. This is our study team. We have a big study team. We work collaboratively with the University of Illinois at Chicago, the COIP, which is just an amazing group that provides a lot of the services that we provide. I should say, of course, that any opinions that I express today are just mine and do not reflect that of NIDA or any other funder that we have. So here's the detail of our randomized trial and our study. It's been a wild ride, partly because COVID has completely messed up so many things that we were trying to do, as I'm sure many people here have experienced. And I should note that at one point, the Illinois Department of Corrections rescinded support for our study because they said that they don't think that a randomized trial of something this sensitive is appropriate, and they don't support placebo trials. And what rescued our study was that we explained that this is not a placebo-controlled trial, and I'll talk about the two study arms that we have. Basically, one arm that we have is a case management peer recovery specialist set of services, and another arm is a overdose education naloxone distribution arm. And we do not want to see differences across our treatment arms in access to overdose resuscitation resources or harm reduction services. That's really important to the way we think about the work that we do. Okay. Here's just our specific aims. I won't go into the details, partly because I know we're behind. I will note one point that's been raised in a really interesting way throughout these past 2 days in the context of clinical care around a lot of issues that I actually don't have any expertise about, which is to really understand the importance of the granular realities. Policymakers and the public like to argue about addiction treatment and needle exchange and naloxone distribution and harm reduction in very broad terms. Does treatment work? If you just look at an op-ed in the Washington Post, you'll see something like treatment works. Does syringe exchange work? Does naloxone distribution work? And that's a little bit like saying, does cancer treatment work? You have to get way more granular to be saying anything that's valuable. And working in what way, for what outcomes, for whom, and in what context. And understanding that we observed a treatment control contrast in some outcome is just of limited value unless we understand the organizational capacities and contextual factors that made that possible. Remember, we did a study 2 years ago of an intervention for people leaving the Cook County Jail. We set up some trailers off-site, and we were worried people were going to leave out into the night into the west side of Chicago and end up being homeless or overdose, something like that. So we set up an intervention where we said to people, hey, if you need a place to stay overnight, you can just come stay in these trailers and we'll hook you up with services. And we were hoping, by the way, we would also reduce violence and criminal, reoffending with this. Our intent to treat effect on violence reduction was 0. And the reason it was 0, it was embarrassingly simple, but gets to the importance of this granularity, which was a lot of our older borderline homeless dudes with serious drug issues loved this, and they flocked to these interventions. And our younger guys looked at those older borderline homeless dudes and they said, I am not that guy. I am not that guy. I got plenty of places to go, plenty of people to call where I can go tonight. And we failed to design and present this intervention in a dignified way that would not trigger self-stigma. And so we failed in one of our primary aims. And one of the things that's so important is to understand what is the self-conception of the people we're trying to help? And are we really providing an intervention in a way that people will embrace? And if we don't do that, we are failing. It's funny, the discipline of implementation science, I think, has many parallels to some of the clinical ethical dilemmas that we see. John Updike once wrote that his short fiction seeks to give the mundane its beautiful due. I don't know if anybody here is a John Updike fan. And his prose was probably too direct and too graceful to fit in most of the implementation science journals, but he was right on point with that. I got 0 credit for that joke. Apparently people don't read implementation science journals to know it. It's very jargony. So just let's see. Here are our study sites across Illinois. I won't say too much about it, except that we really cover the entire state. Downstate Carbondale area, people speak with Southern accents very often. They love the St. Louis Cardinals. I have a video. I have a St. Louis Cardinals cultural competence video for our staff that explain who Lou Brock was and stuff like that. To rural LaSalle County, which is near Starved Rock, and Chicago and Lake County, much more prosperous liberal areas. And so, here's what we do. We started out, we wanted to understand how a sort of case management linkage intervention could be helpful. We know from the literature that people have a really high rate of overdose right when they leave jail and prison. Within the first 2 weeks, there's a dramatically elevated mortality risk. So when we first started conceiving this study, we said, how can we link people to services right when they leave and show that those services are effective? And I don't have to explain to this audience why that's a really important question. And then we started thinking, well, how do we design a randomized trial where we really are honoring the humanity of everybody, including people who are not going to get these services? Because we want to show that these services are effective, but we want to do that in a way that we can live with ourselves. And we want, people, now, sometimes people say, well, everybody gets a gift card if they agree to be in the study. That doesn't cut it. We owe people a lot more than that. And our staff believes that we owe a lot more than that. One of the interesting things that we found with our studies is that if the staff believes that there's a dramatic difference between the treatment group and the control group, and that someone that's assigned to the control arm of a study is not being treated with full humanity, there's a real temptation to defeat the randomization. And we try to take that really seriously. And so we altered our study design so that we had one group of people who got the case management intervention, but we had another group that really got some nice overdose education, naloxone distribution, referrals to local harm reduction resources. And we just think that's really important for us. And we also thought, as we did this study, wow, this has broader implications for every study that we do in our lab. And as part of our design process, when we do a new study, we're trying to formalize what can we do to help everybody in every treatment arm. How am I doing on time, by the way? I'm doing, I'm going to give 2 other talks. Now, and I should say that there's, and one of the things that I've decided as a lab director for my components is I'm not going to do placebo usual care designs if there's any alternative that gives more benefit that is scientifically, that allows us to achieve our scientific objectives. And so we have a new policy where we really part of our study design process specifically says, how can we design a scientifically valuable study that helps everybody? And what do we owe all of our study subjects? How can we improve or safeguard their lives and still achieve our scientific aims? And I should say that trying to hold ourselves to this standard brings us some real challenges and costs, and it brings some benefits too. Among the challenges, it sometimes weakens our statistical power. We do things for people in our study arm that we might consider our control arm, that weakens the contrast across the treatment arms. And and that sometimes makes our studies more expensive, both because we are doing more services to people in both arms, and also because we need a larger sample size, given what we think is a reasonable contrast across our arms and our primary outcomes. And there's some questions that we really can't study. What's the value of giving people services versus giving people no services? That's, in a lot of contexts, we're really not equipped to answer that question, because we don't want to be in a position of offering people no services. And I must say that it's sometimes our funders sometimes are expecting that kind of a contrast. But I must say that counterbalancing that, we have found some incredible benefits to this kind of a policy as well. One is that our study subjects are more willing to participate when they know that they're going to get a benefit that is more than an Amazon gift card or whatever. And maybe most striking, it improves the morale and the pride among our staff and partners who are more willing to enthusiastically support an explicit randomized design when we explain that we're really working hard to benefit everybody. And particularly in the post-George Floyd era, our young staff members who are much more willing than in the past to ask some really uncomfortable questions and to challenge us. They're much more willing to stick around and really be in these studies when they don't have a sense of moral injury that they're sending people to an arm of a study that they feel is not helping people. Now, and as I mentioned, this also rescued our study. So, the Illinois Department of Corrections, when they heard about our study design, how everyone benefited, they said, we rescinded our support, but now that you've explained to us that everyone benefits, we're feeling good about what you're doing, and we're willing to have you come and do this work. And I think increasingly, when you're working with public health partners, you have to have legitimacy with them around these ethical questions. And as a result, we're now out in the field helping people with our study. And, I'm really grateful that IDOC was able to work with us. Let me just close with some lessons. One is, as I mentioned, the necessity and the limitation of randomized designs. I think some people in public health have become much more skeptical of randomized trials. And I am a strong believer that there's a ton of interventions that you just learn so much more from a randomized trial than you can from other study designs. But for every study, we really have to ask the question, what do we owe everyone? And how do we honor the humanity and protect the essential interests of everyone in our studies? And, the opioid epidemic is just the most dramatic case that we've experienced, because, we're going to have people, a decent number of our study subjects are going to die over our study. They're going to overdose and die. That's pretty, if you look at any street cohort of people with active opioid use disorders, a couple % per year are going to have fatal overdoses. And so, how do we operate in that situation? It's the most dramatic case, but it's also a lens and mirror that reveals issues in our own oversights that have come up in many other studies where we're trying to help the most vulnerable and socially marginalized people in our society who most need our help. And I think I'm going to stop there, but I'm very interested in entertaining a conversation. I'm sorry, I wish that I was trying to come up with analogies to the book of Job and to various other famous philosophers, but I think for this particular talk, I'll have to stop here.
We have 1 minute.
Oh.
1 minute for questions.
So I have a quick question about, this concept of a placebo arm, right? Because even like when you're testing a new drug, the placebo arm isn't no treatment, right?
Yep.
It's just no additional intervention above the standard of care. So it seems like it could be interpreted as an argument against the placebo arm or just an argument of what counts as the standard of care right now or what should be the standard of care. So I guess how do you view the difference between those two things? Like obviously you had interventions that you felt would create moral distress to not offer. So is your argument there just that this is the standard of care, even if it's not being adequately provided most of the time?
Yeah, I guess the difference between what we are doing and what many of you are privileged to do in clinical settings at University of Chicago Medicine or elsewhere is the usual care is so terrible for most of the folks that we are trying to help. If you're leaving, so like the Illinois Department of Corrections, they don't allow methadone in the facility. They're very, very poor linkages to care. And we just know that many of the people, when they leave the correctional setting, are going to have terrible outcomes and are going to be lost to a lot of services that they need. And so I think we have a much more acute dilemma than you would experience in a high quality medical care setting where usual care is genuinely high quality, although not as good as perhaps what you could demonstrate with an innovative treatment. It is if you just go down to the Cook County Jail and just spend some time observing the lives of people, you realize that usual care means usual. They're not getting basic things that they need. So that would be my answer.
Thank you.
Yeah.
So we're nearing the end of really what I think has been a wonderful 2 days. It only seemed appropriate that so many people have had the opportunity to thank Dr. Mark Siegler that we give Dr. Siegler an opportunity to reflect for a few moments. So Dr. Siegler.
Thanks so much, Peter. All I can say is, wow, what a fabulous program, and what a thrill to be here in person with you here in the audience. Also to those in our virtual audience, I want to thank you for joining us for this year's 34th Annual MacLean Conference on Clinical Medical Ethics. Let me extend my warmest congratulations to Dr. Peter Angelos, not just on this weekend's conference, of course, his first conference as the new director, but also as the new director for the past 6 months of the MacLean Center. Congratulations, Peter. Peter's been a close colleague of mine since he did his MacLean Fellowship here at the MacLean Center in 1991-92, and then he joined the University of Chicago in 2006 and headed up the thyroid surgery program and was also a faculty member of the MacLean Center from then forward. As many of you know, Peter has helped to create and lead the field of surgical ethics in the United States and internationally, and has trained, I believe, over 120 surgeons in the last 12 or 15 years. Peter has been ably supported by Ann Wang, Director of Operations. Where's Ann? There, in the back. And by Beta Baccaracci, and by Renata Dine. So nice to see you. Thank you for coordinating the logistics and considerable communications challenges that make this conference possible. We're particularly pleased with this year's venue, the newly opened David Rubenstein Center here at the University of Chicago, a stunning architectural trophy at the center here of Woodlawn and 60th Street. I want to recognize Kay Buxbaum, who joined us yesterday and today, and delighted that you're able to be with us. Thank you. the conference remembers the late Dorothy Jean MacLean, who helped create the MacLean Center and was deeply committed to its work. Dorothy MacLean believed that education was the best way to improve the world, and throughout her life supported many leading educational institutions throughout the United States. And of course, I want to thank Barry MacLean and his late wife, Mary Ann MacLean, who for 25 years served as the co-chairs of the Center's advisory board. Barry MacLean provided the funds needed to support the program this year at the Rubenstein Center, which, believe it or not, approaches $150,000. I also want to offer my deepest thanks to the MacLean Center's current chair of the board for the last 5 or 6 years, Rachel Kohler, for her superb leadership. For Rachel's superb leadership, guidance, support, and insight as the center moves forward with Peter Angelos as the new director. I also want to acknowledge the MacLean Center's 3 fabulous associate directors, Marshall Chin, Monica Peak, and Lainey Ross. They've been with us. I want to just say a few quick words about Dr. Wendy Levinson, who this year won the MacLean Prize of $50,000 for joining us from Toronto with her husband, Dr. Jim Shaw. Now, both of them served for many years on the faculty here at the University of Chicago. Wendy's talk opened our eyes to a new and important frontier for physicians. Climate change is upon us. Witnessed the stunning and unusual summer weather a few days ago that we're still enjoying, had been enjoying in mid-November. She gave a wonderful talk about climate conscious care. In addition to our 16 speakers currently on the faculty here at the University of Chicago, it's wonderful to note that we had speakers from 24 universities in the United States, including Harvard, Yale, Columbia, Northwestern, Oregon, Cleveland Clinic, Mayo Clinic, Duke, University of Michigan, Johns Hopkins, University of West Virginia, University of Oklahoma, Ohio State, Wisconsin, Vanderbilt, Albany Medical College, Stanford, Baylor, Virginia, Indiana, University of Houston, and St. Thomas University in Minnesota, and 2 international schools, Toronto and Buenos Aires. Yes. I'm deeply humbled as I reflect on the intellectual power and breadth of learning represented by all of our presenters over the course of these 2 days. It's impossible to single out people by name or to thank you individually, but please accept my sincere gratitude for your contributions and professional dedication. To each and every one of you, my heart is full as I recall your friendship, your time with us as fellows and faculty, and your presence with us this weekend. In closing, let me say that I look forward to seeing you at future conferences and perhaps an even greater in-person attendance in the coming years. Wishing safe travel and a good year of health. Until we meet again, let me welcome Dr. Peter Angelos to conclude the conference. Peter.
Thank you. So I cannot be as eloquent as Mark, but I do want to thank all of the speakers. You have been outstanding. I want to thank everyone who participated online as well as in person. And really, a conference like this only succeeds through the engagement, the careful consideration of complex ideas that we have had the last 2 days. So I really want to thank you all very much. I will echo Mark and wish you safe travels for those of you who are traveling. I hope that you will be marking on your calendar October 27th and 28th of 2023, when we will have next year's conference. So thank you very much.